Welcome to everyone in the part 1 video of adreno-cortical disorders. Here we are going to see Cushing syndrome or hypercortisolism, and first we see introduction and various causes of these hypercortisolisms, and also we go through the clinical features, morphology, and many more aspects of this Cushing syndrome. Let's begin with introduction. This is also known as hypercortisolism, and that is either caused by elevated glucocorticoid level, that is exogenously administered, or due to endogenous causes. And the most cases of this hypercortisolism or Cushing syndrome is due to the administration of glucocorticoids due to other disease or no problem to the patient. And various endogenous causes of this syndrome includes the any problem in the pituitary, hypothalamic pituitary adrenal axis. Any kind of disorder in this axis results in endogenous uh, Cushing syndromes, and that is called as a Cushing disease. And next is ectopic secretion of ACTS from non-pituitary neoplasm, and other could be primary adreno-cortical neoplasm, adenomas or carcinoma, and rarely primary cortical hyperplasia. And Cushing syndrome occur 4 times more in women than men, and most frequently in the 20 to 40 years of age. This is the peak incidence age of peak incidence of this hypercortisolism or Cushing syndrome. Here from the figure you can appreciate the causes of hypercortisolism. First, there has been classified as exogenous cause and endogenous cause. These exogenous causes are the reason for the most cases of this Cushing syndrome or hypercortisolism, while endogenous causes accounts for very few cases. And you can see in the exogenous um, Cushing syndrome, you can see there is a iatrogenic Cushing syndrome where the glucocorticoids are administered to the patient for other region, and that glucocorticoids results in the hypersecretion or overproduction of the cortisol from the adrenal cortex, and that send negative feedback to the pituitary gland for the inhibition of the secretion of the ACTS, and that also results in the adrenal atrophy due to reduced uh, amount of the ACTS results in the reduced tropic effect on the adrenal cortex, and so that also leads to adrenal atrophy. And next you can see endogenous has been classified as ACTS dependent and ACTS independent. In ACTS dependent, you can see this pituitary Cushing syndrome, and there is a paraneoplastic Cushing syndrome. This pituitary Cushing syndrome is due to the adenoma or carcinoma in the anterior pituitary, especially tumor of ACTS producing, and that results in excessive production of the cortisol. This cortisol will be overproduced in this condition, but it is not suppressing the secretion of the ACTS from this tumor. And due to increased ACTS production, the tropic effect of this ACTH will be higher in the adrenal gland, and that results in adrenal hyperplasia. And this accounts for about 60 to 70% cases of the total Cushing syndrome that is caused by the endogenous reason. And paraneoplastic Cushing syndrome is like that non-pituitary neoplasm in the various site that results in secretion of ACTH, which act on this adrenal gland, resulting in the overproduction of the cortisol. And those example could be like small cell carcinoma of lungs, and various other like pancreatic neuroendocrine tumors, and so many other things. And in paraneoplastic Cushing syndrome, there can be any non-pituitary or non-hypothalamic tumors that results in excessive secretion of the corticotropin releasing hormone, and that also results in uh, ACTH secretion. And next you can see in ACTH independent, there is adrenal Cushing syndrome that accounts for 20 to 30% cases of the Cushing syndromes. And here in adrenal Cushing syndrome there could be like hyperplasia of the adrenal cortex or adenomas or carcinoma of the uh, this adrenal cortex, and that also results in excessive secretion of the cortisol, and there is no excessive stimulation from the ACTH. So this is called as ACTH independent. You can see in ACTH independent the hyperplasia is less commonly seen. You can see that in nearly all cases that is caused from the endogenous region are present with ACTH producing adenoma and rarely present with corticotroph hyperplasia or CRH producing tumor or corticotrope cell hyperplasia. And next that variable degrees of bilateral nodular cortical hyperplasia can be appreciated in patient with Cushing syndrome, that is like micronodular or macronodular hyperplasia can be seen in patient with Cushing syndrome. And ectopic ACTH that we discussed earlier in paraneoplastic Cushing syndrome, where non-pituitary tumors were secreting the ACTH, and that is like a small cell carcinoma of the lungs and other neoplasms like the carcinoid, medullary thyroid carcinoma, and pancreatic neuroendocrine tumors, and various neuroendocrine neoplasms that may produce ectopic CRH other than in the hypothalamus, and that also causes ACTH secretion and hypercortisolism. These things can also be seen in some people. And next you can see the ACTH independent Cushing syndromes that results from the adrenal adenoma in about 10 to 20% cases, or carcinomas in 5 to 7% cases. And there is high level of serum cortisol but low level of ACTH due to the negative feedback inhibition of this ACTH secretion from the anterior pituitary corticotrope cells. And molecular defect that can be appreciated are like the activating recurrent activating mutations in the beta catenin, that is CTNNB1, and inactivating mutations of TP53 and MEN1 or PRK1A. And these are appreciated. These mutation, inactivity mutations, are appreciated in both corticotropical, uh, adrenocortical adenomas or carcinomas, and also in micronodular hyperplasia. In those things, this can be appreciated. And next, you can see this primary cortical hyperplasia is also the cause of ACTH independent Cushing syndrome, and this is less common than this cortical uh, ACTH dependent adrenal cortical hyperplasia. That means that hyperplasia that results due to the other causes, that is ACTH dependent, like the pituitary adenoma secrete a lot of ACTH resulting in the hyperplasia of the adrenal gland, and that hyperplasia is more common than this already uh, occurring cortical hyperplasia due to some ACTH independent regions. And there is bilateral micronodular adrenal hyperplasia and also bilateral micronodular adrenal hyperplasia. So let's begin with this bilateral one. Here the nodules of the in the adrenal cortex are less than more than 10 mm in diameter, while in that of micronodular that is less than 10 mm in diameter. And there is familial forms and also sporadic forms. And in familial forms there is a germline mutations in this ARMC5 gene, while 50% of sporadic bilateral macronodular adrenal hyperplasia presents with this mutation. And cortisol production is not regulated by ACTH, rather it is regulated by some other hormones like the gastric intestinal peptide, luteinizing hormone, and antidiuretic hormone. And all these hormones are acting by the G protein coupled receptors So any epigenetic changes that occurs in these genes that code for these receptors results in its overexpression. So that also results in the increased sensitivity of the cortisol production, and this occurs in the setting of the MCQ Albright syndrome sometimes. That is due to the genus mutation, where the alpha subunit of Z protein coupled receptor is mutated due to certain region. And next you can see bilateral micronodular hyperplasia, where the nodules are less than 10 mm in size, and that occurs in two settings. First is a primary pigmented nodular adrenocortical disease, and next can be as a part of the Carney complex. And both are associated with mutation of the regulatory subunit of the CMP dependent protein kinase, and that is encoded by PRKAR1A gene. And this function in the same way as genus mutation, causing the increased intercellular CMP levels. In the like manner, this mutation also act in these disease. Now we see the morphology of this Cushing syndrome. First, we will see the Crook-Halline changes, where the normal granular basophilic cytoplasm of the ACTS producing cells, that is the corticotroph cells in the anterior pituitary, has been replaced by the homogeneous lightly basophilic, and this lightly basophilic is due to the accumulation of the anterior keratin filaments in the cytoplasm. Due to this accumulation, this basophilic cytoplasm becomes lightly basophilic. And next, the morphologic changes depending on the cause of hypercortisolism are as like cortical atrophy and diffuse hyperplasia, or micronodular or macronodular hyperplasia. So such things can also be seen in the setting of this Cushing syndrome. So various other things you can appreciate these features as cortical atrophy is seen in ACTS independent condition, where the ACTS is not stimulating the overproduction of the cortisol, but instead the overproduction of this cortisol eventually leading to the suppressed secretion of ACTS from the corticotrope cells of the anterior pituitary, that is causing the reduced tropic effect of this ACTH on the adrenal gland, that results in cortical atrophy. But sometimes diffuse hyperplasia can occur, and this happen in ACTH dependent condition, where although the cortisol is suppressing the secretion of this ACTH, but due to overproduction of ACTH due to like pituitary adenoma or ectopic causes, the ACTH level is still higher, and that is showing the tropic effect on the adrenal cortex, resulting in the diffused hyperplasia, and that hyperplasia could be micronodular or micronodular. Then we see bilateral cortical atrophy, that is suppression of endogenous ACTH in patient with hypercortisolism, especially of the zona fasciculata and reticularis. That means tropic effect of this tropic effect of ACTH is mainly seen on zona fasciculata and reticularis, because we know that glomerulosa is independent of ACTH stimulation, and so the thickness of zona glomerulosa will be normal, while uh, that of zona fasciculata and reticularis will be atrophied in case of those uh, where there is a suppression of endogenous ACTH in patient with hypercortisolism. And cortical hyperplasia, these occur in endogenous hypercortisolism, that is endogenous in ACTH dependent, especially like in pituitary adenoma that produces excessive ACTH, and also in the paraneoplastic syndrome in association with Cushing syndrome. And diffuse adrenocortical hyperplasia can be seen in ACTH dependent Cushing syndromes, and certainly are markedly bilateral enlargement of adrenal glands can be appreciated. And similarly, Variably, nodular or thickened adrenal cortex can be seen, and vacuolated lipid-rich cells, giving the yellow color to the gland. Such features can be seen in this diffuse adrenal cortical hyperplasia and primary cortical hyperplasia. There is a cortex replaced entirely by the macronodules or 1 to 3 mm darkly pigmented micronodules, and this pigment is of lipofuscin. That you can see here that lipofuscins are being accumulated in these micronodules, giving the pigmentation to the micronodules, and such things are seen in primary cortical hyperplasia. And next, we can see the various clinical features in Cushing syndrome. First, early manifestations could be like hypertension and weight gain. We know that there is a permissive action of cortisol and the catecholamines, and that results in increased beta adrenergic actions, and that results in hypertension, and weight gain is due to the lipogenesis. And also there is a more centripetal redistribution of these adipose tissues that present as a truncal obesity, and a rounded faces, accumulation of the fat in the posterior neck and back, that is called the buffalo hump like manifestations, and selective atrophy of fast twitch, that is type 2 myofibers with decreased muscle mass and proximal limb weakness. And next, action of glucocorticoids can be seen as like increased in gluconeogenesis and inhibits the uptake of glucose by the cells, and that results in secondary diabetes as well and lead to the hyperglycemia, glycosuria, and polydipsia, that is diabetes like symptoms, and also results in the loss of collagens, and due to that reason the skin becomes thin and fragile and get easily bruised, and cutaneous stripe can be seen especially in the abdominal area, so abdominal stripe can be seen. Next, we can see that effect of cortisol on the calcium metabolism. So, what effects can we see that are reduced renal reabsorption and increased urinary loss, and that lead to resorption of the bone and osteoporosis. So, and this happen in the setting of compensatory mechanism to the reduced uh, plasma calcium level, and the bone becomes more susceptible to the fractures. And glucocorticoid also suppress the immune response, that is patient with increased risk for infections in case of Cushing syndrome due to suppression of the immune response, especially cell mediated. And hirsutism, menstrual abnormalities, can also be seen in female, and psychiatric symptoms like mood swings, depression, and frank psychosis can be seen, and increased skin pigmentation due to melanocyte stimulating hormone secretion, because this ACTH and MSH both has the precautions, same precautions, and due to increased ACTH secretion, that will show positive feedback to the increased production of ACTH, and also MSH production will be more, and that results in increased skin pigmentation, and also ACTH level will be elevated uh, in both pituitary and ectopic Cushing syndrome, but ACTH level will be low if that is due to Cushing syndrome is due to iatrogenic or adrenal tumors causing hypercortisolism. And this much for now. Thank you for having patience.